Hello and welcome to Heritage Foundation. I am Andrew Parks, the Associate Director of Lectures and Seminars here at Heritage. Thank you for joining us in our Lewis Lehrman Auditorium. I just wanted to take the opportunity to remind folks in-house to silence cell phones as a courtesy to our panelists and to those watching online. For those watching online, you're welcome to submit questions by emailing speaker@heritage.org. Hosting today's program is David and Sarah. He's the Research Associate for Homeland Security and Cybersecurity in the Douglas and Sarah Allison Center for Foreign and National Security Policy. David?
Thanks, Andrew. At the end of 2013, the current Ebola outbreak began in Guinea, West Africa. Over the course of 2014, it became the most deadly outbreak of Ebola since the disease was discovered in 1976. Not only did the disease ravage West Africa, it also spread to other countries, including the United States, where it became the topic of frenzied discussion and worries. While the outbreak is in remission, the purpose of this panel is to learn from this outbreak so that the U.S. and the international community can be better prepared for the future. This is not the last time we will see an Ebola outbreak, and it's certainly not the last time we will see an outbreak of any other dangerous pathogen. And so Heritage assembled a group of public health and emergency preparedness experts to analyze how the outbreak was handled, what mistakes were made, and how we could do a better job next time. Their work culminated in this report here, which is available on the Heritage website, and the panel here today will be discussing the report's findings. And so with that, it is my pleasure to introduce our panel. I'll introduce them all here at the start, and then we'll let them all just give their remarks in order. And so with that, I'll start with Dr. Daniel Kaniewski. Dr. Kaniewski is the Mission Area Director for Resilience and Emergency Preparedness and Response at the Homeland Security Studies and Analysis Institute, HSSAI, a federally funded research and development center serving the U.S. Department of Homeland Security. In this role, he oversees the Institute's emergency management, infrastructure protection, and cybersecurity studies. Dr. Kaniewski is also an adjunct assistant professor at the Georgetown University School of Foreign Service, where he teaches graduate courses in the Security Studies program. Before joining HSSAI, he was the assistant vice president for Homeland Security at the Homeland Security Policy Institute at the George Washington University. He has also served as a special assistant to the president on Homeland Security and the senior director for response policy in the George W. Bush administration. Prior to his White House service, he helped co-found the Homeland Security Policy Institute at George Washington. He has also held positions at the Federal Emergency Management Agency, the Congressional Fire Services Institute, and has worked on Capitol Hill. He began his career in Homeland Security as a firefighter and paramedic. Dr. Kaniewski holds his PhD in Public Policy and Administration from the George Washington University. After that, we will have Charlotte Florance. Charlotte Florance is an international policy expert concentrating on economic freedom, democratic institutions, development, and security cooperation in Africa and the Middle East. She is a policy analyst here at the Heritage Foundation's Allison Center for Foreign Policy Studies. Before joining Heritage in 2013, Ms. Florance was a research fellow responsible for international security and foreign policy issues on the Senate Homeland Security and Government Affairs Committee. She previously worked in Kenya with a local Catholic Relief Services partner organization, St. Joseph's Shelter of Hope, as a program development assistant. Ms. Florance continues to work with and advise social enterprises in East Africa, and she serves currently on the DC board of Indigo Africa, a nonprofit organization dedicated to women's economic empowerment. Ms. Florance also serves as part of a IRI, International Republican Institute, election observer mission to Tunisia in 2014. Her commentary and analysis have been seen in multiple publications, including the BBC Radio, Huffington Post, and the Washington Post. She has received her Bachelor of Arts from the University of Southern California and her Master's from the War Studies Department at King's College, London. Following Charlotte, we will have Dr. John O'Shea. Dr. O'Shea is the Senior Fellow for Health Policy at Heritage's Center for Health Policy Studies. Before joining Heritage, he worked at the Engelberg Center for Healthcare Reform as a visiting scholar for 15 months. Prior to that, he worked as a Senior Health Policy Advisor for the Committee of Energy and Commerce in the House of Representatives, and he served there for 3 years working on numerous healthcare-related issues. In 2006, he served at Heritage as the Harvard Graduate Fellow in Healthcare Policy, and he's also a surgeon who has practiced surgery for over 20 years, mostly in the Bronx. He has authored numerous publications related to healthcare policy as well as the clinical practice of surgery. And lastly, we will have Dr. Pham. Dr. Pham is the director of the Africa Center at the Atlantic Council in Washington, D.C. He has previously held an academic appointment as a tenured associate professor of justice studies, political science, and Africana studies at the James Madison University in Harrisburg, Virginia. As an expert on international relation and strategic issues, Dr. Pham has authored over 300 essays and reviews and is the author, editor, and translator of over a dozen books on the topic. Dr. Pham currently serves as the Vice President of the Association for the Study of the Middle East and Africa, which represents over 1,300 scholars studying those topics. And he's also the editor of that organization's Journal of Middle East and Africa. A staunch advocate of robust American engagement with Africa, Dr. Pham has also served on IRI delegations to various African countries, including Liberia in 2005, Nigeria in 2007 and 2011, and Somaliland in 2010. And so with that, I'll turn over to Dan, and then we'll just go in turn.
Great. Thanks, David, and thanks to all of you for joining us today. It seems like a long time has passed since the Ebola crisis here in the U.S. and internationally. But let me just take a step back and talk about why we did this and why we're talking about it today. I have to admit that the brainchild of this effort was David's boss, Dr. James Carafano, here at the Heritage Foundation. And last fall, when the crisis was kind of unfolding, he called me and a couple other of the usual suspects in the Homeland Security area and said, hey, I think it's time we engage on this particular issue, just like we've done, just like Heritage has done on a variety of Homeland Security issues over the years. And the more we saw it unfold, the more similarities we saw between previous crises. So then taking that perspective, which again, my perspective today will be the domestic side, he then reached out to Charlotte, seated to my left. And Charlotte is an expert in the international perspective on the Ebola crisis. And I know that she's going to provide you a wonderful overview of that. So again, today my remarks will be focused on the domestic issues. And I should also note that I'm speaking in a private capacity and not on behalf of my organization. So with that, the three areas I would like to highlight for you on the domestic front are three of the sections in the report: the public health and medical response, the federal leadership within our government, and lessons learned. So first on the public health and medical response. Overall, we found that healthcare workers in the U.S. lack the necessary training, equipment, and experience to protect themselves and respond effectively to this bio event. We also found that senior political leaders, specifically at the state and local level, both didn't understand Ebola, the virus, but they also didn't understand their roles and responsibilities in a pandemic scenario. You saw this probably most clearly with the governors of New York and New Jersey offering conflicting guidance and even issuing conflicting orders, specifically around quarantine within their particular states. You can imagine that if it went to additional states, it could be quite complex and quite complicated. I'll let Dr. O'Shea speak specifically to the medical and public health perspective, as he's obviously the expert as a medical doctor. But I want to say one last thing about public health and medical response, and this comes from Dr. Bob Kadlec, a member of our committee, and frankly, someone who is a thought leader in this area. And he said, we need to take a step back and realize that we need to integrate preparedness throughout the federal, state, and local public health agencies. And just as DoD emphasized jointness in the 1986 Goldwater-Nichols reorganization, the public health community, too, should refocus its efforts on integrated preparedness. And this would involve much more than just HHS, right? It would involve the Departments of Veterans Affairs, DoD, DHS, and a number of other federal departments and agencies that truly need to be integrated in a joint way, similarly how DoD had to learn this kind of the hard way in its early existence and finally came around in 1986 with Goldwater-Nichols. so again, I think that was a great takeaway from again, a leading thinker in this area, Dr. Bob Kadlec. The next topic, federal leadership. If any of you remember back to when this crisis was unfolding, you recall that there weren't senior Obama administration officials publicly engaged in this. And what do I mean by, first of all, senior administration officials and two, publicly engaged? Well, senior administration officials to me means more than just the CDC director. And certainly the CDC director is an expert in Ebola, and certainly he leads an important organization within the federal government. But Dr. Frieden is by no means capable in his position as CDC director to direct the entire apparatus of the U.S. federal government and focus all efforts on this particular crisis. To do that, you'd really need someone more senior. So let's kind of look up the chain of command in HHS, which is just one federal department, that is involved in the response. The CDC director manages that agency. The Assistant Secretary for Preparedness and Response is a senior position within the Department of Health and Human Services who oversees a number of aspects of HHS related to biopreparedness and bioresponse, not just CDC, but as you know, HHS is a very large department. You know, other organizations like NIH have important roles to play in the Ebola response. So the question that was raised, that became most apparent, I guess, to us, and the question we raised was, what was the role of that Assistant Secretary for Preparedness Response during the Ebola crisis? The short answer is we don't know. That person was not publicly engaged. The person may have been engaged behind the scenes, unbeknownst to us. But our big takeaway here is one of the lessons learned from Hurricane Katrina when I served in the White House was that there needed to be a senior HHS official that was coordinating the health and medical response to that disaster. And Congress agreed with that and passed the Pandemic and All Hazards Preparedness Act in 2006 to ensure that this did not happen again, that Katrina with the medical consequences did not happen again, and they statutorily created that position of Assistant Secretary for Public Health Preparedness and Response. So again, the question we raise is what was that person's role? And it's apparent to us that that person was clearly not empowered during the response. And the Ebola czar, we all knew the Ebola czar was appointed. I think there was more news about when the Ebola czar Ron Klain was appointed than anything subsequent to that, right? How much have we heard, how much did we hear from the Ebola czar following his appointment? Not much. Again, internal coordination, behind the scenes likely at the interagency process, but unclear what that position played. And regarding that position, I would argue, the committee argues, that position should have been made permanent a long time ago. Someone who could coordinate interagency biodefense policy efforts at the White House. And in fact, that position did exist. It existed while I was at the White House. In fact, the aforementioned individual, Dr. Bob Kadlec, held that position as Special Assistant to the President for Biodefense Policy. The position was eliminated during the Obama administration. And so this ad hoc approach of bringing in an Ebola czar and functioning in some kind of role that, again, is not apparent to anybody that was on the committee, should have been a permanent position at the White House, and we call for in our recommendations for that position to be returned to the White House, to that Special Assistant to the President for Biodefense Policy to be reinvigorated, and to ensure that the next time this happens, we don't have an ad hoc response at the White House. I'll close by mentioning lessons learned. Again, as part of my background that I was at the White House during Hurricane Katrina. I started 1 month before the disaster, and for the next 3 years, I dealt with the after effects of that disaster. Most specifically, my boss at the time, Fran Townsend, she was the President's Homeland Security Advisor, led a review of that disaster, and we published a report called The Federal Response to Hurricane Katrina, Lessons Learned. And let me emphasize, we published a public report. You can Google it right now and see what the White House felt the major failures were for the response to Hurricane Katrina. And that followed, what followed was 125 recommendations on how to improve the federal government's response to future disasters. I asked the question, what has the Obama administration done in the wake of Ebola to give us confidence that every action has been reviewed and that recommendations going forward have been made where the federal government will resolve the issues that we highlighted in our report going forward.
Thanks, Charlotte.
All right, thanks, David, and thanks, Dan, for kind of giving an overview of the domestic side of our report. I'll be focusing more on the international aspects. But, something that I think we hosted a panel last fall during the height of the crisis and the media's coverage, and at that point in time, it was, you have to deal with the problems here in the U.S., but it's also, the U.S. is only as safe as the weak health systems in West Africa. And so ultimately looking at the fundamental issues in West Africa or vulnerable developing nations, particularly with diseases like Ebola, is critical. So my role in the task force ranged from writing contributions to kind of bringing together, we had about 10 plus experts that provided insights as well as recommendations, findings to our report. Dr. Pham was one of those individuals, and the topics ranged from transmission, looking at cultural and societal factors, humanitarian assistance, efficient trade rules and facilitation, long-term impacts and economic stability, World Health Organization reform, lessons from Nigeria and Senegal's successful containment efforts, and then the overall U.S. government response in West Africa. So the two broad takeaways from the international sections of the report kind of first included it's critical to improve medical training and increase access to effective and sustainable health care for West African countries. I think a broad theme throughout the report is that the private sector can and should play a large role in the development of those systems. And then second, it's important to strengthen lines of authority and narrow the priorities of the World Health Organization to focus on a limited number of core responsibilities, so they can do them well. There is a reform process happening at the WHO right now, but the results of that I think are still very unknown. So while these two major takeaways have broad implications, I thought I'd focus on two specific elements today. And with this being the Heritage Foundation, I'd be remiss if I didn't talk about trade in the UN. So first, I'd like to highlight my colleague Ryan Olson, Ryan Olson's contribution to the report, which focused specifically on trade in West Africa. As you all know, trade is an important component to the discussion on improving and strengthening public health systems, but it's not always the first thing we think of. Most of the affected countries are small and lack the indigenous capacity to manufacture the supplies needed to address public health needs. So securing international markets for supplies and pharmaceuticals is critical, but reforming the inefficient systems and costly local customs procedures and regulations that are in place is equally important. While most of the affected countries did implement emergency customs procedures during the crisis, these did not constitute long-term reforms. And beyond just Ebola, additional health challenges in these countries, this would be an area to improve overall health access, not just for Ebola victims. So take, for example, Liberia. Once a shipment arrives at port, it takes an average of 29 days for goods to arrive at their destination. There are 12 documents required for processing, and the cost to import is around $1,300. The documentation preparation process alone takes an average of 3 weeks. And then these types of delays are an even greater threat to sensitive products that require refrigeration, vaccines, and other medicines. And then if you put this in the context of, to put this in the context of the OECD, average processing times there are 9 days, an average of $1,000, and require 4 documents. Most of this is done through e-governance or online platforms where procedures can be done even before shipments arrive at port. So some of the specific recommendations within this space included, again, reducing delays by cutting documentation, permanently instituting fast-tracking and duty waivers for medical supplies, life-saving supplies that are needed beyond just Ebola, victims, and then kind of additionally speeding up Liberia's World Trade Organization accession timeline. And second, focusing on the UN's health agency, the World Health Organization. I'm sure many in this room are familiar with the WHO's failed handling of the Ebola outbreak in West Africa. The Director General, Dr. Margaret Chan, has been relatively public on this issue and the agency's internal failings. And while some reforms were announced last week, which are certainly welcomed, they're not formally approved until next month after the External Review Committee shares its findings. And additionally, what those reforms look like in practice and the speed with which they're actually implemented does require additional analysis and oversight. So we're not out of this area in WHO reform by any means yet. And ultimately, the WHO was slow to respond. But when it was forced to act, the agency was woefully unprepared to coordinate the international community's response. Groups like Doctors Without Borders went so far as to say the WHO failed in its mandate to help member states cope with health emergencies. Leaked internal memos from the WHO highlighted similar concerns. And this isn't a new story. Similar criticism occurred during the H1N1 outbreak, commonly swine flu, in 2009. And there was a similar external review investigation, like the one going on today, that produced a list of needed reforms, but in practice those were never implemented. Fast forward to 2013, and we see the same types of failings that occurred with the Ebola outbreak in West Africa. And kind of beyond this emergency preparedness component of the WHO for epidemics, in recent years, the WHO has expanded its areas of focus and spread limited resources more thinly to campaign about issues such as childhood obesity. While I don't dispute that obesity is a problem, I see the WHO playing a far more constructive role in strengthening the capacity of developing nations' health systems, kind of one of its core competencies. And then these systems, as I mentioned, directly affect the health and security of the United States. Some of the specific recommendations from the task force included narrowing the organization's priorities to focus on a limited number of core responsibilities, including building national health capacity, monitoring and tracking disease outbreaks, developing national and regional outbreak response plans, coordinating and managing rapid deployment commitments, and encouraging development by the protection of intellectual property, vaccinations for neglected diseases, and new antibiotics and treatments as resistance rises. Additionally, encouraging multilateral and bilateral health funding and building public health expertise and capacity in developing nations. Again, there's opportunities for public-private partnerships in this space. And strengthening lines of authority and responsibility in the WHO to avoid repetition of the inefficiencies that slowed the WHO's Ebola response and further exacerbated the situation. As many of you know, the hiring process in the WHO is highly political, and so kind of reforming that process as well will also help to bring in capable and competent people that are knowledgeable about the duties put before them. So with that, I'll conclude my presentation, and I look forward to your questions. Dr. O'Shea.
Thank you very much, and thanks for including me on the panel. And I think that the report that has just come out will really serve as a very thoughtful and comprehensive and valuable resource on this important issue. What I'd like to do is just make a few very brief comments about what I see as the role for the U.S. medical profession in combating the Ebola virus. And certainly the events surrounding the case of Thomas Duncan's entrance in the United States and the infection of two of his nurses generated public fears and led to substantial criticism, a lot of misinformation and even overreaction that was not very helpful in the initial going in the experience in the United States. The CDC, which at least initially seemed a bit caught off guard, I think pretty quickly issued some new standards, for one thing for wearing protective gear, and new screening procedures were put in place at many of the major airports in the United States to check for patients that might have a fever or had the appropriate travel history that would put them at risk for exposure to Ebola. And for example, the CDC mandated that all travelers who arrive in the United States from West African countries where the disease was present be monitored by officials for a 21-day incubation period. But nonetheless, as we saw at the end of October, Dr. Craig Spencer, who had returned from treating Ebola patients in West Africa, was confirmed to be infected with the virus and had somehow slipped past the checkpoints. And there was also, as I think Dan alluded to, more stringent regulations were put in place in New York and New Jersey for doctors and nurses that were returning from West Africa. And this led to the highly publicized quarantine of Casey Hickox, an epidemiologist who was working to treat Ebola patients in Sierra Leone. And she was quarantined even though she tested negative for the disease. And this certainly generated not only criticism and confusion, but it also raised concerns about whether these heightened restrictions would deter doctors and nurses from volunteering to travel to West Africa, specifically at a time when more healthcare workers were desperately needed. So certainly there were a number of missteps early on in the U.S., but I think the CDC and others in the public health and emergency preparedness communities have responded. There are now guidelines and screening procedures in place. And going forward, I think ideally, the screening procedures for people traveling from affected countries and at the entry points in the United States will be robust enough to intercept those patients, those people that are suspected of being infected with the Ebola virus. But this is certainly no guarantee, as was seen again in the case of Dr. Spencer in New York. So in that case, the line of defense may come down to individual encounters between a doctor and a patient. So what can the medical profession do? And I think first and foremost, medical professionals in all specialties need to be up to date on accurate information about the disease. And I think this is essential to dispel fears, undue fears, and also to promote prevention, detection, and timely and appropriate treatments. And since the symptoms of the disease can be nonspecific and include fever, headache, muscle aches, for example, nausea and vomiting, and symptoms that are really can mimic more common and certainly less dangerous diseases, that physicians should maintain a high index of suspicion, but they should also be able to assure their patients that without the associated travel history or exposure history, that their symptoms do not represent an infection with Ebola. Second, I think physicians should ensure that proper protocols exist and are followed in both their offices and in the hospitals where they work. In addition to the CDC, medical professional organizations like the American Medical Association, the American Association of Family Practitioners, and the American College of Emergency Physicians and others have developed resources to assist in preparing and implementing these protocols. And certainly there's a wealth of information available on the websites in these organizations. And the American College of Surgeons, for one, has even developed guidelines for the unlikely event that an Ebola patient would need surgery. But although the concepts behind the protocols are standard and they've been applied in dealing with other highly infectious diseases, they will likely need to be further clarified or modified when they're implemented at the local level. And certainly the medical profession can play a critical role in ensuring that the protocols are not only followed, but that they're appropriate for the local institution. And although at this time it appears unlikely that an Ebola outbreak would occur in the U.S., I think the recent experience should be an opportunity also to assess the preparedness of the emergency medical system to respond to the threat posed not only by an epidemic, but by natural disasters, bioterrorism, or any other mass casualty situation. Certainly a local emergency medical system that has difficulty dealing with day-to-day capacity, is overcrowded, has to board sick patients in the emergency department because there are no beds in the hospital, is more likely to suffer a breach in what can be labor-intensive and time-consuming prevention protocols, or they may even miss the rare case of Ebola when and if it presents. And finally, I think U.S. medical profession should also continue to take a leading role in international efforts to fight the disease at its source and in research efforts to develop vaccines and new treatment options. Biomedical research initiatives are currently underway in the U.S. and elsewhere to develop new treatments and vaccines against the virus. And in addition, while most American doctors cannot reasonably be expected to volunteer for service overseas, a number of physicians can and already do travel to affected countries to volunteer their time and expertise. So I think that while the U.S. and the American medical profession should be as prepared as possible, it should also be remembered that epidemics like Ebola can only be overcome by stopping the spread of the disease in the affected countries. So I'll leave my remarks there. Thank you.
Thank you. And I'd like to start by thanking again Charlotte and the rest of the team at Heritage for involving me in this process. It's always a pleasure to come back to the Heritage Foundation. It's been more than a quarter of a century since I came to Washington as an intern here at Heritage. It was a much smaller place, and it's nice to see the expansion and progress here. Also, I'd like to acknowledge my associate director at the Africa Center at the Land Council, Josh Maservi, who joined me here and was involved with the task force as well. My brief is to talk as an Africanist to discuss the African countries that were affected, but I'd like to reserve most of that for, we can deal with the recommendations and some fine recommendations in the report about the long-term impacts, the economic stability, other issues, and certainly be happy to address that in the question and answer. What I thought I would do instead in this brief presentation is to highlight actually some lessons learned by two African countries that were not in the immediate hot zone of Guinea, Liberia, and Sierra Leone, but which actually managed the crisis quite well and have a few lessons for those of us in other countries that have to deal with a epidemic that arrives on one's shores. And there are basically two lessons that we can derive from Senegal and Nigeria, very different experiences with Ebola in terms of scale and threat, but two general lessons that are common to both. One is that an immediate, broad-based, and well-coordinated response, as Dan brought up earlier, is critical to stopping the disease in its tracks. And the second one is that immediate, broad-based, and well-coordinated response has to include three elements: the thorough tracing of contacts, the ongoing monitoring of those contacts, and if necessary, the effective isolation of those who proved infectious. And it's rather interesting that these two African countries managed both rather effectively with very little input from the outside world. So it's a positive story from Africa as well as one of lessons learned. First case is Senegal. Senegal borders, of course, Guinea, one of the high-impacted countries, and in the weeks and months leading up to the arrival of the disease in Senegal itself, they were already well aware that this was a threat to them, already put in place at the presidential level, per Dan's suggestion earlier, at the presidential level, already put together a coordinated mechanism for the multiple government agencies that were involved, directly answerable to the office of the president. And then when the case arrived within their borders, a student from neighboring Guinea who crossed the border, they quickly identified by going through anyone he had been in contact with, whether through casual contact or healthcare workers involved in his treatment, identified 74 people who had been in contact with the index patient. All 74 people were identified by government officials, subjected to twice daily checkups by medical personnel, and monitoring for the entire incubation period. At the same time, and this is rather interesting, went largely unremarked at this time, Senegal closed its 330-kilometer-long border with Guinea. Senegal is one of the more professional militaries in West Africa. They set the military to the border. They sealed their border. They also closed air links and maritime links with the affected countries. However, at the same time, they created at the airport in Dakar a seamless corridor for humanitarian personnel and equipment and supplies to get to the infected countries and for humanitarian to get out, demonstrating, I think, that border security and the prioritization of lowering the risk to one's own citizens is not necessarily inimical to the efficient delivery of aid to others. And so the end result was that Senegal, at the end of the 42 days, actually Senegal had only the one index patient, and he survived. The other kind of interesting thing that Senegal did, although this student was not a Senegalese citizen, was they kept his name anonymous. He wasn't identified. And it's an interesting comment from Dr. Awa Kolsek, who was the Senegal's Minister of Health. She said that the key was reintegration of the recovered patient into society that would understand that he no longer posed a risk of contagion. And the best way to do that was to protect his anonymity, while at the same time directing assistance in the form of money, food, and counseling to those he may have impacted in order to incentivize them to participate in the monitoring system. And so at the end of the 42 days, twice the incubation period, Senegal was declared disease-free by the World Health Organization. The other case was entirely different in terms of scale. Nigeria, which does not share a land border with the 3 infected countries, had an infected Liberian government official, Patrick Sawyer, who flew to Nigeria and literally collapsed in the arrivals terminal at the international airport at Lagos. As a result of that, he infected not only people on his flight, potentially, but also customs officials, other passengers, and literally people at the luggage carousel. Nigeria didn't wait to, as in the case of the United States, which waited 3 weeks to appoint an Ebola czar, and as we've heard, we're not sure what the Ebola czar did. Nigeria, within 3 days, had established an intergovernmental coordination mechanism. They quickly identified, going through with the airlines, the travel agencies, hospital administrators, to identify 900 at-risk people whom Sawyer, the man who arrived, and those who had been in contact with him themselves potentially transmitted the virus to. In order to identify these 900 people, Nigerian government officials, a combination of police to ensure the ability and enforcement of the action, and medical personnel visited 26,000 homes and conducted 18,500 interviews face-to-face and checking with people. And that's how they yielded the 900 people potentially who they had to keep an eye on. And as a result, they kept an eye on monitoring them and in some cases, if necessary, imposing a quarantine on them. The net result at the end of the day for Nigeria, a country of 175 million people, the patient landing in Lagos, a city of 20+ million people, was there were only 20 confirmed cases from this index patient, and only 8 deaths resulted from it. Again, very robust, quick action. And in both cases, these are countries that have none of the resources, certainly that the United States and other more developed countries have in this room. Nigeria perhaps is a little further advanced. It is Africa's largest economy, but still that they quickly swung into action in a coordinated fashion and had the political will to do that. And so there are 2 examples, I think, of lessons that could be learned, that if certainly the political will can be found and the flexible government mechanisms and coordination of state, local, and federal authorities. And in the case of Nigeria, it was actually the Lagos where the patient landed was actually in opposition hands at the time, and the federal government a different part, but they worked seamlessly together very quickly, and I think happy results for both countries. And I think there's a lesson to be learned from that, at least on the broad principles. So with that, I'll close my presentation and certainly be happy to address some of the other Africa-related issues and recommendations in the report. Thank you.
Thank you, panel. At this time, I want to open it up for question and answers. We have 2 microphones around the room. We just ask that you state your name, any affiliation, and then just rather tersely ask a question. I'll take questions and we got one right here, so we'll start with you, sir.
Gerald, Chandler, Vitek Consultants for Dr. O'Shea. I think you just said that there is some danger of medical personnel not wanting to go to the infected areas because they may not come home or if they easily, or they may have to be in quarantine. Is there any actual polling data that talk to medical professionals that verifies that? And it seems unlikely to me because people who are willing to risk their lives to go to the infected areas, it seems like they are making a sacrifice, and if they had to make a further sacrifice to stay home from work for 3 weeks, wouldn't find that as big a sacrifice as going to the infected areas.
Yeah, good question. I have not seen any data that there's been an effect on willingness to go to other countries. And like you said, I think that's a humanitarian choice, basically. I brought that up mainly because that was a big discussion around. That was just a highly publicized and I think pretty much bungled event surrounding those heightened restrictions in New York and New Jersey. And that was certainly at least part of the discussion around there. But I haven't seen any data where it's affected choice to go to other countries and serve.
Hi, my name is Carrie Lajeunesse. I'm a Science and Technology Policy Fellow in the Office of Congressman Jeff Fortenberry. And Dr. Pham, I wanted to thank you for what you brought up about Nigeria and ask you, one of the things that worked there, I had a friend that was part of that response and trained up Nigerians to do exactly what you talk about with contact tracing. Can any of you comment as to where in our policy we look at part of our emergency response working deeply, immediately with local citizens to get this training for contact tracing and getting people into isolation? One of the biggest issues has been trust. David Nabarro's talked about it a lot at the UN. What are we doing to deeply engage these communities and scale up thousands of people who can then go out into these communities and locate all of these contacts?
Well, I think that the reason thank you for your question. The reason I brought up actually the Nigerian example is it shows what can be done. I'm not sure we're doing it, to be quite honest. And it really, the Nigerian effort really was an amazing effort that involved heavily the private sector. I mean, there was the government aspect of it, which was the coordinating mechanism and sending out the police to accompany the medical personnel to get the door open and to get the less willing to cooperate, shall we say. But there was a whole social component. I mean, it was amazing what they did. Using a group of volunteers came together in something called Ebola Alert, in which they use social media, Facebook, Twitter, and other social media to educate people very quickly. They partner with the government to operate a telephone helpline to spell any irrational or unfounded rumors that were flying, which is always a danger, especially in less developed countries. There was even a mobile app developed to do this. And then, again, with the private sector, they got these apps out so that the information being collected by this contact tracing was available in real time. It wasn't lags of several days. So it clearly shows the potential of what can be done. And one would think and hope that in more advanced economies and societies, we could do even more, but it takes that political will and that willingness, and quite frankly, that we haven't seen that. Perhaps some of my colleagues have seen different, but I haven't seen it, and that's why I highlight it.
I guess something that I think is perhaps interesting within the sub-Saharan context is the layering upon existing programs. And so I think Nigeria on top of polio tracing, but I think there's also space where programs could be improved upon, particularly with community health workers in the PEPFAR program. You already have individuals that are trained to look for TB, HIV, and malaria. And so and something you do see in Uganda with their kind of constant challenge with Ebola epidemics. But
Cheryl Washington with the National Center for State Courts. I know there was some discussion about the governors in New York and New Jersey and some conflicts in terms of their recommendations about quarantine. Can you talk about any effort as you were preparing the study and coming up with recommendations to reach out to various state executives and discuss how in the future, there may be some discussions, especially among states that border each other, while I think each state has a right to come up with some degree of, their own recommendation. Just, can you talk about any effort to reach out at the state level?
I think that's an excellent point. As you touched on, this is a states' rights issue. The federal government doesn't issue quarantine orders, governors do. And state health departments play that key role in advising the governor on what to do in those situations. I'll say that the state's view was outside the scope of this particular study, and due to time and resource constraints, we weren't able to go out and interview governors and state officials. I would have loved to have done that, and that's actually a great follow-on study. And I got to think that the various state and local public health organizations have contributed in that area. I would say from a federal standpoint, what's clear to me is that the federal government needs to do a better job of providing proactive guidance in these situations. And Dr. O'Shea mentioned that briefly. And more fundamentally, the federal government needs to make sure that it plans appropriately for this scenario and other scenarios that we can imagine that could occur into the future. And we lump all that under preparedness. So whether it's what the Department of Homeland Security does with preparedness, providing grants and technical expertise to state and local governments to plan for a variety of scenarios. I think it was touched upon that all hazards preparedness is certainly something that I personally embrace, so that we're not preparing for yesterday's disaster tomorrow, because we just don't know what will strike in the future. But the federal government has a key role to play here, but it's not a preeminent role. It's not one where they're going to dictate to the states what to do, but they can provide some best practices, some guidance, and in many cases, funding to help plan for these types of scenarios.
I had a question that perhaps the panel could touch on, which is that the military response, the U.S. response in Africa. I just was wondering if some of the panelists could perhaps comment on what the proper role of the U.S. military or international community would be in countries that are affected by this by Ebola or future diseases, similar diseases, and how did that ideal role match up with what we actually did? Maybe Charlotte or Dr. Pham. I'm not sure if you guys have any expertise in that.
I guess, and just in terms of international emergency crises, while the U.S. military's response to Ebola was unique in that it was a disease outbreak, that type of international assistance isn't something new for the U.S. military. Most recently, kind of prior to Ebola, was the crisis in the Philippines, and so it's something that they, are. They're the most capable logistical entity to do it. Whether they're the most appropriate, I think, kind of came up in discussions rather severely in the Ebola outbreak. I know Dr. Pham was mentioning earlier kind of the actual results of what happened on the ground, kind of concerning in terms of facilities. I think it was probably a lot too late. But Dr. Pham.
Charlotte's point's well taken, that there are few organizations, not just in the U.S. government, but across the globe, that have the logistical capability of response as the United States military. And so I think the larger question is whether it's the appropriate use of that the logistical capacity. But then within the specific context of Africa, what we found also was that there was a bit of a hiccup after the announcement was made by the president of this deployment of 3,000, initially the initial announcement of 3,000 personnel to do this. For whatever reason, I think someone failed to look that the U.S. Africa Command, which is the military organization responsible for the continent of Africa, doesn't have 3,000 personnel if you sent every last mechanic, office assistant, and everyone else. There weren't 3,000. So it took a while to actually find personnel. The deployment actually never got to 3,000. The Army took the initial lead, and then the Marines stepped in. So that was the question of resourcing. Then it was the decision of how to engage was made, and then it was the classic, the train left the station, and at the end of the day, we now know that some of the facilities that were constructed have, literally some of them have never treated one patient. There are other facilities that were built that treated literal handfuls, and others where the construction was never actually completed for the reason that the crisis abated. So I think the comment about a lot late is well taken. So I think there's some lessons learned to be had from this, and I know the military is in the process of doing that, and we'll wait to see the results of that. And I think there will be some key lessons for the next time something like this occurs.
Okay, this is as a former UPS executive. As you were talking about getting, Ms. Florance, the import barriers to goods delivered, I mean, some of these delays to import and the cost to import seem unconscionable. Is there something in the works? I mean, are you thinking of maybe a round table with logistics executives to talk about this? I mean, I would think the humanitarian cause here would, I know this is a long-term, not an easy-to-solve kind of problem in, many countries around the globe, but is there something to maybe jumpstart the effort?
Yeah, there's actually, I haven't been following it as closely within the past couple of months, but at the kind of height of the outbreak, there was a private sector working group created that brought together mainly logisticians. So you did have, I think DHL and UPS were a part of that, along with several of the large private sector firms in these countries that do have experience moving goods through. So I know in Guinea and Sierra Leone, you did have several mining companies. I believe some rubber companies were involved in those conversations on this is how we are able to get supplies and things through. This is where there are opportunities for the humanitarian effort. But there's definitely still plenty of room for discussion in that space, in particular because a lot of those things were emergency measures that were not permanently instituted into the system's customs procedures in those countries. So that's one area that I hope that I know Heritage will be. It's something that we kind of rank in our index of economic freedom on kind of non-tariff barriers. And happy to connect you with one of my colleagues here could probably provide some more insights onto that if you'd like more follow-up.
Any other questions? All right. Well, I want to thank you all for coming out to the Heritage Foundation today, and I hope you can all join me in giving our panelists a round of applause.